Welcome to the MindSea podcast series, Moving Digital Health. Our guest today is Mike Lovas, Director of Design and Innovation for Cancer Digital Intelligence at the University Health Network, Canada's largest research hospital network. Thanks for joining us today, Mike.
Thanks. It's great to be here.
Now, your background's pretty unique, extending from biomedical engineering to product design. Can you give us a bit of an overview?
Yeah, for sure. I guess I started out doing an undergrad in engineering and then a master's in biomedical engineering, and then worked in that field for a while. Before, I went back to school and did product design at OCAD University to try to kind of see things from a new light, try to get things, look at problem solving from a more creative and human-centered approach. And then through that experience, I ended up doing a bunch of different consulting work. One of which ended up into a startup that I was in with a couple of other founders in sport technology. And then fast forward a few years, I ended up taking an offer and to lead the design team at Healthcare Human Factors, a healthcare innovation group. And we worked across the health spectrum, doing work across the board with innovators and researchers, hospitals, et cetera, including a bunch of cancer work. And then in 2018, I actually was diagnosed with cancer myself, and so it was it was like a shocking flip of the script where I was seeing things from the other side. And it was really, obviously life-changing experience from kind of an emotional human side of it, but then also from a professional side, it was very much kind of a pivotal point in my career where I realized that a lot of the cool innovation work that we were doing as a consultancy was not, it was kind of getting stuck in research trials and not necessarily seeing the bedside. And so after that, I ended up partnering with a radiation oncologist and the then head of the cancer center to start an innovation program called Smart Cancer Care, and we started in earnest during the pandemic to kind of meet the needs. We kind of pivoted once the pandemic hit and really ramped up to try to meet the needs of virtual care for cancer patients to kind of enable continuity of care during the pandemic. So we did that for a number of months, and then once things settled down, then we got back to the stuff that we were planning before, which was really around trying to rethink how the patient experience for cancer care was or was being delivered. And so it's on the patient side, but then also on the provider side. It became very clear and very obvious pretty quickly that the same kind of bad systems and old processes and technology were making it challenging for patients, and similarly, we're making it challenging for providers to do their jobs well. And so, yeah, we've been working hard ever since. We've kind of expanded the team and actually merged with another team since then to create this kind of larger team called Cancer Digital Intelligence, which again is multifactorial, but a large part of my work is still around the patient experience, provider experience, using kind of innovative or new ways of thinking, new service models, and new technology to try to change things for the better.
Okay. So beyond virtual health, what does cancer digital intelligence look like? Or like what are some of the concrete examples of some of the innovations there?
Yeah. So a lot of the work that my portfolio focuses on is around remote or virtual care. But we take a pretty broad view of virtual care or remote care. And so it's not just the video visit, it's thinking outside the box to think about how we can really tie in the patient experience and help support patients throughout their cancer journey from end to end. And so that looks at kind of reactive support structures and infrastructure so that if something comes up, tomorrow while the patient's at home, they have a way to get in touch with their care team. Our cancer center is super complex, and so there's a ton of different actors on the care team and on supporting teams, and so it's not obvious for the patient who they should be reaching out to and the best way to do so. And so oftentimes they're sending out many messages to many different people at the same time, which is super inefficient and challenging for everyone. Or they end up kind of sucking it up and waiting until their next scheduled visit, which might be a couple weeks away. Or I don't know. Sometimes the worst case scenario is they end up in the ED and sitting waiting for hours and hours, and then seeing somebody who doesn't necessarily understand the nuances of their cancer treatment or disease. Um, and so, yeah, we're trying to shore up that kind of reactive service offering so that we can support patients throughout and provide a better triage service. So that's on the reactive side. On the proactive side, we're really thinking about how we can kind of, especially for high risk patients and patients undergoing treatments with high symptom burden. So a lot of our systemic therapies and some radiation medicine, and some folks who have maybe concurrent chemo and radiation at the same time. We're looking at we have developed a number of different programs for remote patient monitoring, which essentially links the patient up with some technology that will allow them to passively input their biometric data. Think like a wearable temperature patch that continuously reads their temperature to signal for fever, febrile neutropenia, which is something that brings a lot of patients into the ED right now, or some manual processes like asking patients to fill out a symptom survey at a regular cadence, like twice a week. And so the combination of those two things really gives us a good picture of how the patient's symptoms are doing over time. Some patients end up, they're on treatment and they don't know, a lot of patients go through cancer for the first time, like myself. And so you don't necessarily know what's coming next and what you should be expecting as the kind of normal course of treatment. And so oftentimes patients kind of suck it up because it's like, well, I'm on chemo. Of course it's going to be bad. They said it was going to be bad. I didn't know it was going to be this bad. And so they just assume that it's normal, where there's lots of kind of self-care or other treatments or modifications of the existing therapy that can be done to kind of minimize or mitigate the symptom burden. And so that's remote patient monitoring as a concept has been around for decades in cancer. And so we're trying to put it to work, not in the research context, but actually operationalize it, which is a challenging and complex task, but we're pushing forward with that.
Yeah. And how does the family become involved? Because I know, like, technology can be challenging for some cancer patients, especially the elderly. Are they involved in that process as well?
Yeah, so a lot of these programs allow for either the patient or the caregiver to kind of submit the query or the symptoms on their behalf, because you're right. It's, going through cancer is definitely it's very, very challenging to do it solo. And so often people lean on their friends and family for support. And so, yeah, that's definitely open for their caregivers.
Yeah, I've had a few members of my family been diagnosed with cancer, so I've kind of experienced, that journey, secondhand through them, and it can be widely different, right? Like, one patient's chemo and experience can be so much different than another, and if they only have one reference point of someone they know that went through cancer, and theirs is very different. Again, they don't know what to expect or what's normal.
Yeah. Yeah, absolutely. Yeah, and that's kind of one of our overarching, like, kind of long-term goals is to we're working on really ingesting a lot of this data so that we can do kind of reactive or proactive support. But that's kind of at a symptom level often, and some administrative side of it as well. But as we're gathering this data and understanding the needs better, it kind of opens up and unlocks this opportunity to really start creating more nuanced or kind of, I don't know, bespoke programs and services for different individuals who, yeah, might have a, I don't know, a really rare cancer, or they might be at really high risk for symptoms or for mental health issues, et cetera, or financial struggles. And so this, being able to start flagging this and understanding the data and understanding our patient population, it's starting to allow us to see the opportunities to develop other services. Like, for instance, um, we've been working with other groups at UHN around e-navigation, which is, I mean, it's a navigator program that can be enhanced by electronic technology. But this is something that's, I think, has a lot to offer. There's a ton of nuance in it, but like a peer navigation program or something similar where patients are matched up with previous patients or trained navigators to help them across their cancer journey deal with whatever the specific details are that they find themselves in. We have a program for AYA, so adults or adolescent and young adults with cancer. So as you can imagine, that's very different for somebody going through that, where they're dealing with, challenges at school and their friends and different things like that, which is very different from a 74-year-old who's retired and going through prostate cancer, for instance. Um, and so some of those navigator programs will be interesting to help support the kind of human side of things.
Yeah, of course. And then, so what form does that program take? Is that like an online portal where you kind of log in? It has information about the journey, and then connects with that peer support group, like you mentioned.
Yeah, so there's a few different variations of it, and I've been involved in, again, I don't know, several versions of this over the past several years. So I want to shout out to Jackie Bender and Andrew Matthews, who have a couple of these different programs. Um, but yeah, there's sometimes or often there's a matching component where the patient kind of inputs some of their details, again, depending on their circumstance. It might be age, gender, sexual orientation, cancer type, treatment type, location. And then on the back end, there's a roster of peer navigators or trained clinical navigators who will be paired based on demographics or preferences or experiences. And so that's kind of at the front end matching. And then once you get in, there's often there's like channels of communication. So either secure messaging or video calls, which are fairly straightforward for the patient. But on the back end, there's lots of kind of support structures so that um, coaches or navigators can see their whole roster, how long they've been spending, when the last time they reached out to their paired patient, etc. And then beside that, there's also like kind of usually an educational side of it where there's a kind of detailed, specific information that's available for the patient, and then the navigator can kind of help the patient work through some of the education. So those are the main things. It's really, I think the matching is a big piece of it, and again, that requires the data to be surfaced up front, um, and then having a big roster of navigators to support the different needs.
Yeah, and what has the patient feedback been on having those enhanced tools.
Yeah, I mean, I'll pivot back to the work that we're actually doing. That stuff I was more consulting
Right,
on
right.
those navigation
Mhm.
programs, but I think they're an important piece. But the work that we've been doing around the reactive stuff and the remote patient monitoring, I think patients being able to get in touch with a trusted member of their care team quickly, especially when anxiety is higher, they're really worried about a symptom, is super critical. So that our reactive and our proactive systems or services kind of respond to that, and so patients feel a great sense of kind of relief and almost like a safety net that, as they're going through this really challenging time and as symptoms come up, they feel like they can trust that their care team is there for them even when they're not physically in the hospital, which is kind of the old model where you have to show up to be kind of seen, whereas now, um, we with algorithms and different kind of service models in the back end and different kind of affordances that technology allows, we're able to care for patients more seamlessly throughout their journey without them having to be in the cancer center.
Yeah. And so what do you think the biggest thing that you've learned, working with those patients, that you didn't know before joining UHN?
Um, yeah, I mean, jumping off from what I was just talking about, I feel like um, it's become very clear that patients kind of suffer and struggle at home alone. And after doing my own kind of time study and then talking to a bunch of subsequent patients and patient partners, it's been become very clear that patients spend the vast majority of their time as cancer patients at home or at least outside of the cancer center. And so if we're expecting to really support patients with their cancer journey, throughout, and um, expecting to understand their trajectory, their treatments, how things are affecting them. We can't just rely on those individual scheduled visits. Um, and so, yeah, I think another kind of slight tweak on that is I now realize that cancer patients are incredibly grateful for, generally or often life-saving treatment, which is awesome, and it means that they don't necessarily always give us great, like, constructive feedback because they're so grateful for the
Right,
care
like
that
they would
we've given
feel
them.
bad almost giving critical feedback because they're just so happy to have that support.
Exactly, exactly. And so in the end, it's often like, life-saving or, really has improved the patient's quality of life and their lifespan, et cetera, at the end. But the early phases, especially coming in, patients, if they've come out on the other side, they forget or they gloss over or they minimize in their mind, either consciously or not, they kind of minimize the challenges that they've had throughout. And so that's one thing that we've been trying to do is try to um, gather feedback in real time, as patients are going through the different services, so that we can bring it in again in real time when they're potentially having struggles instead of waiting 6-12 months after they're okay to get their feedback. And we're doing that at high like scale now where we're getting tens of thousands of responses for experience measures, to get a better sense of how we're doing. Um,
Yeah, when
and then
we're
yeah.
I was just going to say when we're user testing a product like a mobile app with someone, often we have to be very clear at the beginning that, you know, we're looking for critical feedback. Nothing you can say is going to hurt our feelings, and that's where you can provide the value is with the criticism. it doesn't help as much just if you say that, this is great. So the more we can kind of encourage people to do that, the more value we can get out of that feedback.
Yeah, for sure. Yeah, I often say something to the effect of that we're testing the product or the service, not you. So like there's no wrong answers. And then obviously to make sure that they know that their feedback is not going to get back in the hands of their care team, is a really important one.
Exactly. So, considering these different tools and how they can be used to improve cancer care, how do you go about selecting, which initiatives to move forward with? Because I'm sure there's no shortage of ideas of we could do this, we could do that, and lots of support behind that. But you know, prioritizing and selecting which ones to do is sometimes the biggest challenge.
Yeah. Yeah, no, it's a great question. I mean, we do a ton of things. So I've only given you a small sample of the different projects that we do. We also have a bunch of asynchronous work going on, which is looking at like radically new models of care that are don't exist right now. Um, we're building a command center. And then there's our whole kind of AI ML side of the house and digital or data infrastructure. I think if I'm being honest, initially it was as we were smaller subset, two smaller teams that eventually came together. We had kind of a general thesis um, for each of our portfolios. And so we've been rolling with those different theses. So our program was really again around kind of stitching together the patient experience from end to end and improving it and provider experience with new models of care and technology. Um, and so we had that thesis, and we had a few different projects or programs with under that banner. Yeah, so as our programs have started individually, we each had our own thesis of what the work that we should be doing was. And so our program was really around stitching together the patient experience end to end and enhancing it and the provider experience using new models of care, new technology, being data informed. And so we had a number of ideas on how we could do that. And so to be totally frank and honest, we've rolled out a bunch of different pilots or seed projects, as we like to call them, and in a very what we call agile service design. It's a real kind of almost like lean startup where we develop these programs, we roll them out, and under a QI banner, we are constantly iterating on the product or the service, which looks at changing the technology, the features, the UI UX, but also the workflow on the clinic side, which is a massive like that's I don't know 80% of the battle is like the human workflows. um, and and so we just iterate, and as we roll it out, as we get more feedback, as we scale, we understand and shift and change the technology and the service. And I can give a more concrete example. We started this reactive stuff, the digital triage work. We started that a couple years ago, and we started by cobbling together a bunch of internal systems, just different Microsoft tools that were within our ecosystem already, and we have some like tech wizards on our team who were able to kind of hack them together, and we went through privacy, security, etc. Um, but we built that together, and then we launched it knowing that that's not the end goal, it's not the finished product, but we launched it in one or two clinics to see how it would work. We got the feedback, and we started, you know, fairly substantially changing the kind of components of the tools. And then after, I don't know, 5 or so months, we actually made the decision to move all of our learnings, our workflows, um, kind of the feature requirements into Epic, which is our EMR that just, we just rolled out in June. And so that was something that wasn't available to us before. And now that we saw how the rollout of the patient portal has gone, and we now understand the technology and the platform better, that we feel comfortable translating or transferring that knowledge, those workflows, that service into Epic, so that we can scale it up and mature the kind of tech stack. So that's kind of an example that, like, we've iterated on the technology several times over the last, I don't know, year, let's say.
That's amazing how you're able to work in such a lean and agile fashion within healthcare, which is typically not the way things
Yeah,
happen.
yeah.
So
I
it's for me, I love hearing that. It's really exciting.
Yeah, I mean, I won't say it's easy, and I think coming out of this, I don't know, these last year and a half, we have a ton of learnings that somebody should hold my feet to the fire and get me to write them up. Because I think you're totally right. It's not common in healthcare. It is not. It is not the preferred way. There's it's not linear. It's harder to kind of schedule and manage. But I do think there's a lot of value that can be had if you have the kind of stomach for it, and you can build the right kind of alliances with the different teams in a healthcare system to make it happen.
Hmm. And of all those different projects or initiatives you've tried, is there one that you can single out as being the most impactful uh, in over the last few years?
Um, I mean, the biggest impact that we had was definitely in COVID. Um, I would say because we scaled immediately, our virtual care work was, I don't know, we started and rolled it out within 2 weeks, and it was, tens of thousands of patients went through it instantly. Um, and which was really around rescheduling, kind of triaging and rescheduling all patient visits during COVID to try to minimize the number of patients that would need to come into the physical hospital, and kind of decant the others to virtual care or defer them their next visit. And so the logistics around that were a nightmare, and incredibly complicated. And so we developed all of these workflows and then tools, and stitched together a bunch of different technologies to make it all work, so that patients didn't fall through the cracks, and that this could happen within a couple of weeks instead of months. And so we saw our virtual calls go from 0.25 pre-pandemic to, I think, upwards of 74% within the first couple of weeks of the pandemic. And so that was, like, definitely the most, like, fast impact work, where all teams were running in the same direction, and we had kind of unique knowledge of the data, like our clinical workflows and service design to kind of pull it off. um,
Yeah, like
but COVID feels
hearing you talk about that, I'm thinking like all the different skill sets and experience and knowledge that are required to pull something like that off. Like, tell me about some of the different roles of the team members you work with.
um yeah, I will say kind of cross disciplinary folks who, for whatever reason, are naturally gifted at that, or just have a ton of experience at it. So some people that come to mind are the medical director, Ali Berlin. He's a radiation oncologist by training, but he's, I think, by nature, just a hacker and somebody who figures out how to get stuff done regardless of anything, whether that's physically making something, or digitally making something happen, or politically getting something through. Um, and then Tran Trong is on our team and has been worked in at UHN for a number of years, and so she really has a good lay of the land in terms of the digital and data architecture across the board, and has a ton of personal relationships with other folks in the kind of IT and digital infrastructure world. And then we have a great team who are health informatics folks and designers, service designers, product designers, who again all tend to have a health background, either formal training or just experiential experience on the ground. And so, yeah, I don't know. It's kind of a mixed bag of random misfits who we bring them together, and they, we're all passionate about the work. We all bring their own kind of skill sets to the table and kind of get stuff done.
Yeah. So, what are the next big innovations in cancer care? What do you want to see happen in the next few years?
The work around operationalizing remote patient monitoring across the cancer center, I think, is will be a huge innovation. And with that, we are rethinking and kind of shifting expectations and roles within the cancer center to better support that model. Um, I think that one is kind of a nice foundational innovation that will allow us to do other things and build other innovations on top of. For instance, once we have that level of data coming through, that's a kind of real time symptom data and biometric data, we'll really have a good, clean sense of how our patients are doing on a given treatment and on any specific diseases. And we'll be able to build, or some folks are already building different prediction algorithms on that data so that we can kind of catch symptoms before they happen. And that kind of opens up this whole idea of intervening, kind of before the symptoms emerge so that we can modify the treatment protocols or the self-care education so that, patients don't get burdened with those symptoms or don't end up in the ED and therefore don't end up being admitted. And so there's a whole host of work around that. And then there's another cluster of work that I've alluded to before, which is around asynchronous clinics, which I think is will become more and more and increasingly important as our treatments get better, as patients live longer with either stable disease or they are in complete recurrence. Being able to, so the volumes of patients who are seen over the long term, are kind of building on top of each other, and is really, they're really kind of clogging up the clinics for, for new patients who need to be seen. And so if we can start decanting patients out of the clinics who are either on maintenance therapy or well follow-ups, who feel comfortable with this asynchronous model of care, it allows us to meet the patient where they are at home without making them kind of drive downtown, wait in traffic, and then park, and then wait in the wait room to be seen for a minute or less to get the kind of thumbs up. And so we're developing these models where the patients can do all of their work. They can do symptom reporting, they can do their labs, their imaging, and send it into a centralized system and then be reviewed on a given day asynchronously, and essentially either be given a thumbs up, like we'll see you again in 6 or 12 months, or we'd like to bring you in for a video visit or physical visit. Those kind of models, it's fairly simple on the surface of it, but the impacts on patient life are huge. The impacts on the system are huge, and I think it kind of opens up a whole new world of thinking about how to deliver care. Um, and so both of those opportunities are kind of clusters of work, but they allow, there's so much innovation, especially around AI and ML. Like there's so many models that can be built once you start having that kind of level of data. Um,
Yeah, I recently heard about how scientists at UBC are using AI to predict how long a cancer patient will live with like 80% accuracy reported just by analyzing the doctor's notes. Um, and I'm curious if, if you have any thoughts on that, or, maybe other examples of how you're using AI.
yeah, yeah. I mean, yeah, that's an interesting one. I hadn't heard of that paper, so if you can send that over, it'd be great. Because I think one thing that we've been focusing in on is around the patient reported outcomes, but then we're also building in clinical outcomes as well. So building that into the EMR, so the fusion of these two kind of streams of data and then other repositories of data. I think once you start fusing data, that's where the really interesting and impactful work can be done. Um, Other areas that I've seen that have been very successful, our wider team has been working on auto segmentation, which is in the radiation therapy world, um, where radiation oncologists spend a bunch of their time, hours of their day, kind of tracing out tumors and tracing out healthy tissue that they want to spare during radiation treatment. And so this is largely a manual process right now, again, which is very time consuming. Uh, but some folks in our cancer center have developed models that will do kind of auto segmentation, auto tracing of the organs based on pattern recognition and image analysis, very accurately and incredibly fast. And so that's some technology that's very mature in our environment, that's been tested and tweaked and iterated on over the last number of years. That's pretty advanced and pretty impressive, the kind of gains that they can get.
Yeah,
Um,
that's a great example.
mhm. Yeah, and I know this one's this one's fresh, so I don't know if anyone's working on it, but an old colleague of mine, Shina Melwani, had the idea of using ChatGPT or uh, GPT-4 now, to kind of decode um, doctor's notes. Um, and so, you know how a lot of results come through the patient portals in kind of medical lingo. It hasn't necessarily been developed for the patient. Supposedly, I haven't tried this out yet, but supposedly, if you put in some results into Chat GPT, it will translate it in lay language at fairly fairly accurately. Again, don't
Right,
quote me on
right.
this,
So
but
just kind of, yeah, translating that jargon into more understandable terms for the average patient, right? That's interesting. So I see that you're also an AMS fellow in compassion and artificial intelligence. So could you tell us a bit about, what AMS is and your role there?
mhm. Yeah. So AMS healthcare is a really interesting and a fairly old establishment. That has looked at, they're interested in healthcare history, but also now more so looking at how we like kind of understanding or appreciating digital and AI are here. It's just part of life now. But understanding that compassion is such an important piece of healthcare, and so how can we understand? How can we not see digital or AI as like a barrier in between, humans that will potentially um, widen the gap or make compassion kind of go away? And how can we see it as an opportunity to either maintain the level of compassion or even enhance it as we move forward? Um, and so that's the organization, and kind of broadly speaking what their mandate is. And so the work that I proposed to them for this fellowship was really around just that, like how can we explore different models that would help encourage or enhance compassion for remote cancer care. And so a lot of the work that I've talked about like earlier in this conversation is what we're really looking at. And so the work is being rolled out and deployed across Princess Margaret. And so part of this fellowship is to, do semi-structured interviews and surveys with patients and providers to understand their understanding of compassion when their care is mediated by a digital solution. We're just doing the early analysis now, and we're kind of ongoing. But some of the interesting insights that I've been seeing are really depending on the patient and the time of care. Um, a big piece of it is again what I've said before, but is like how can I, as a patient, get in contact as quickly as possible with the right person um, to give me trusted and timely advice, feedback, assessment, whatever the case may be. But it's really about timeliness and trust. And so I think um, we're looking at little features and nuances within our workflows and within our services to kind of highlight some of that stuff.
Yeah, it's really interesting just thinking about the faster we can give that patient communication with that trusted provider and give them answers that help relieve their anxiety. That that really is a more compassionate approach, even if it's virtual and not in person. Than the route where they have to wait hours or days to see someone in person.
Yeah, absolutely. And I do want to just highlight the nuances. This isn't like a broad brush stroke. These different kind of interventions um, are nuanced and are applicable for different patient populations. But I will say that a lot of I don't know, the ageism, I would say, a lot of the times people are like, oh, this patient is, over 70, therefore they can't use technology. But that's actually something that over the years, I've actually seen the kind of the opposite effect, especially within remote patient monitoring. Um, Oftentimes we see our older patients who are the ones who are um, the ones who stay on and are the most blanking on the word, but are able to respond over time and don't fall off.
Right, like the
And
most
so,
engaged.
yeah, exactly.
Yeah, that's interesting. Yeah, counterintuitive. Um, but we've seen similar parallels outside of healthcare where people make assumptions about a user of a product or a customer based on their age. But there are a lot of people out there that have picked up digital tools really quickly and are very fluent, regardless if they're over 70 or 30 years old. It's more about the adaptability and also the incentive. Maybe these people are very engaged in their health and they understand that they need to be proactive and to really manage their care.
Yeah, absolutely. In the US, a colleague who's been working on remote patient monitoring for cancer care also found I don't know, 3 years ago in a study that a third of their patients preferred a IVR, interactive voice response, like an automated phone message over a web tool. Um, and so um, that's just an interesting thing about like different channels that are more appropriate or more um, some folks are prefer over the others. Another thing anecdotally that I heard down in the States as well, that some immigrant populations prefer like using WhatsApp over other native applications in terms of a communication tool. And so I think we're moving into this time where it's going to be messy and there's going to be lots of different forms of communication. And so I'm a really big believer and um, strong advocate for the idea of healthcare institutions leveraging platforms like CRMs, customer relationship management tools, to start aggregating this communication data as we send stuff out through email, text message, secure message in the portal, IVR, phone, letter, like physical letters, faxes, etc. As we send that out like that and we get equally a variety of different messages back, it's going to be increasingly important to tie all of that together. And the standard electronic medical record does not do a good job of it. It wasn't designed for that, and so a CRM layer on top is, I think, a really appropriate and useful tool for kind of our frontline staff to be able to keep track of all of that different forms of communication.
Right, right. And to your point before, just gathering that data and collecting it all, even if you don't know what you're going to use it for yet, allows you to build the data set that then you can, go back and use machine learning, use AI to analyze and pull insights out of. But it really starts with, getting that data, getting good data that you can work with.
Yeah, exactly. And I will say it's kind of twofold. It's one, the future work around gathering the data so you can build cool things in the future, but the CRM idea is really around how do we like cleanly collect and organize the data so that a frontline worker who gets a call or a message or sees a patient face to face can effectively and efficiently understand all the things that have come before it without spending 25 minutes digging around in the chart that was not designed for that.
Right, exactly. So it's for the now and the later use case. Uh, Interesting. Well, Mike, I think you've been able to share so many great examples, and I really appreciate you having you on the podcast and sharing your knowledge and insights about digital cancer care, but also just understanding patients in different ways of reimagining healthcare. So, thank you so much for joining us.
Absolutely. It was great to be on.
All right. And thanks for everyone for listening and joining us on Moving Digital Health. If you enjoyed this conversation, please go to movingdigitalhealth.com to subscribe to the MindC newsletter and be notified about future episodes.